Okay, and when we were last together, we were discussing we discussed pulmonary edema, and we're moving into assessment. So now I want to move into assessment and treatment. Before I do that, I want to call your attention just briefly back to the previous slide, the picture here of pulmonary edema. And just want to call out that notice in the picture that the manifestation of pulmonary edema on the chest x-ray is very different from the manifestation of pleural effusion. So while they're both fluid related issues, the way they manifest in the body is very different. So we have to manage them differently. Pleural effusions, we can, as I mentioned before, we could possibly go in and tap the fluid and remove it. Pulmonary edema, in order to evaluate it and manage it, we have to do different things. And that's what we want to talk about. Again, both fluid issues, but the origination is often different. They can be related. Remember, as I've said many times, patients don't read textbooks. So the way patients' problems evolve can be multi-layered. So patients can have both pleural effusions and pulmonary edema and heart failure, and they have this overlapping manifestation, which can make treatment challenging. As we move through this, I'm trying to segregate these conditions so you can see the differences and you can see how therapies work separately to address these issues. Pleural effusions can be addressed with diuretics. That's one way we can try to pull the fluid off, is to do it by changing the concentration in the bloodstream and getting them to pee it out. That can happen. With pulmonary edema, obviously the treatment is going to be based on the cause. Let's talk about assessment and move along here. So, of course, these patients can have shortness of breath. Remember, shortness of breath is a very vague symptom. So then we have to explore further how these symptoms manifest, how severe they are, what exacerbates it. Think old cart. When did it start? What relieves it? How long does it last? Is there anything that makes it better? Is there anything that makes it worse? Has it gotten worse over time? Has it improved any, etc.? So there are a variety of questions there related to pulmonary edema we would pursue just as if we were evaluating pain. So again, shortness of breath, early stages, it's going to be mild. As it gets more severe, those will be later stages of and greater severity of the pulmonary edema. And the severity is going to depend on what the patient has the capacity to tolerate. Tachypnea would be expected because these patients are trying to maintain a minute volume, but they're trying to do it by breathing more often because they don't feel like they're getting enough volume in. So they may be breathing more frequently with lower volume. So tachypnea, definitely a potential symptom here. These patients will most likely have some form of crackles, rales, rhonchi, possibly even wheezes if there's enough edema that it's creating some pressure on the air passages. So we would definitely expect to hear crackles in the lungs, and obviously depending on severity, rales or rhonchi. In the early stages, when there's not alveolar edema, then sputum could be dry. These patients wouldn't necessarily be coughing something up. But in later stages, as it becomes more severe and there is fluid and perhaps even a bit of red blood cells in the alveolar space, then the sputum becomes pink and frothy. Patients can be tachycardic. Why tachycardia? If you think about the fact that there's this excess fluid in the system, the body is trying to alleviate it. The body's trying to maintain cardiac output. The heart's going to be trying to pump harder in order to process this fluid, keep the patient stable. And since they are having fluid in the spaces between where we breathe and the capillaries or the red blood cells, then the body has trouble getting oxygen efficiently onto red blood cells. If that's problematic, then the body's having trouble getting oxygen out to tissues. So the heart is going to say, based on metabolic need, we need to pump more. Think back to chemoreceptors and baroreceptors when we talk about fluid and oxygen and carbon dioxide maintenance. So those are things that are going to also drive tachycardia. So the tachypnea, the tachycardia are going to be ways in which the patient is trying to compensate and improve overall cardiac output to improve oxygenation out to the tissues. Now, since tissues may have issues, since the tissues may be challenged in being oxygenated adequately, then of course patients can have clammy skin and diaphoresis. That can also be a result from the stress of just having to work so hard to try to oxygenate. So that's another manifestation here. And as you might imagine, if someone is feeling like they're drowning or suffocating, then restlessness, anxiety, if we're not perfusing the brain well, confusion, all of those things could be reasonable assessment findings, along with, as you might expect, peripheral edema, because if the fluid backs up in the lungs and it's already causing an issue, then it's going to look for other places to store this fluid, and the periphery is going to get it. So you're going to have swelling in the feet, hands, ankles, perhaps face, jugular venous distension, big neck veins. All of those things are definitely symptoms you might see. As I've said many times, perhaps already in class, we're going to treat the problem and manage the symptoms. Now, sometimes symptom management is important. If the patient's short of breath, the symptom is shortness of breath, and we need to put oxygen on them, right? That putting oxygen on them does not make the problem go away. That's not treating the problem. That's managing symptoms. It's important. It helps the patient breathe better. It helps the patient oxygenate better. The problem is the fluid. So we have to do something to address that fluid management. And that's going to be related to where that fluid's coming from, is back to our causes, cardiac versus non-cardiac. If we have a cardiac cause, we've got to look at cardiovascular medications that can help improve cardiac output, that can help decrease preload and improve oxygenation. If it's trauma, sepsis, take sepsis for example, then the patient definitely, if they're not already, needs to be on antibiotics. We may have to support the septic patient because they're so sick with mechanical ventilation, or perhaps even non-invasive ventilation like BiPAP, if we're trying to avoid a mechanical ventilation. So there may be other things we have to do if it's one of these other problems. If they're if it's an altitude issue, get them out of altitude. If it's blood transfusion and they don't have to have it that fast, slow the transfusion. So you can see how, based on the problem, depends on how we approach solutions. But we have to manage this fluid and we have to get them perfused. The question we have to ask is, what is the most critical problem that's producing and contributing to this pulmonary edema? Is it the pump? Is the heart causing it? Is it the kidneys? Are the kidneys not functioning appropriately? Do we have poor kidney function, kidney failure? So do we need to address kidney function and perhaps move in the direction of a dialysis, whether it's just for this hospitalization or that's the next phase of this patient's care? Is it a liver problem? As we've discussed before, liver failure can produce volume overload problems. Then we have other issues we have to address in the process of addressing that. So in identifying the most critical problem, that helps us identify then what's the cause. And that is back to, like I said just a moment ago, cardiogenic versus non-cardiogenic, because those conditions determine the decisions we make in treatment. Obviously, we want to manage volume, not just the volume that's in the body, but we want to manage volume that's going in. So patients with pulmonary edema, one of the answers is not going to be giving them fluid. We're going to be trying to remove that fluid and try to optimally oxygenate with the tissue that we have. So this picture right here just gives you an idea of how the the mechanism that we see, whether it's increased capillary pressure or capillary permeability or hypoxic pulmonary vasoconstriction, you can see where the precipitating event, the cause, is on the right of that table and the mechanism there on the left. So how we approach the answer is going to be based on the precipitating event and the cause here. So I want you to think about this in terms of these components right here, because these both interventions and evaluation methods help us identify our problems and how we need to proceed. I've already introduced the idea to you about cardiac output. We're talking about pulmonary edema. We can't really talk about pulmonary edema without talking about cardiac output. And cardiac output is heart rate times stroke volume. And stroke volume comes down to force and frequency. In other words, stroke volume comes down to the force of contraction and the frequency. So heart rate, that frequency, how often is it beating, and then how well is it beating and how much volume is in there. So we have to, first of all, think about preload reduction, trying to reduce this fluid. And we can do that by trying to improve blood flow to the kidneys, getting the kidneys to do more work, and increasing the kidney's capacity to move that fluid out. And that's what diuretics are going to do. So our first general intervention for pulmonary edema is going to be, we're going to start with diuretics, most commonly. Try to get them peeing, try to reduce this preload. Now, if we have a bad pump, then we're going to need to improve contractility. Beta blockers and digitalis can improve contractility. They can help the force of contraction in a couple of ways. Digitalis helps with actin and myosin interaction, actually the exchange of sodium in that depolarization that causes that force of action between actin and myosin that increases the force of contraction. Beta blockers have another approach, and that is they slow the heart rate. As you know, they decrease the blood pressure, which makes it easier for the heart to pump. They slow the heart rate, which creates more filling and more stretch, a greater stroke volume. And as you may have heard me say, the greater the stretch, the greater the force of the next contraction. That's Starling's law. So as the heart stretches, if we slow it down, it can potentially beat stronger with each beat. And that may sound counterintuitive. It may sound like we need to beat more, but if we allow for greater filling, that can create a higher contractility on the next heartbeat after that filling. Afterload reduction is that part of the beta blocker that lowers blood pressure. So if we can decrease resistance, then we can improve overall cardiac output. Remember, afterload is resistance. Think about it this way. If you have two people, someone that's like Dwayne Johnson, and then someone that is small and not strong and fit, those two people can move different amounts of weight. Could both of them move 3,000 pounds? The answer is yes. Dwayne Johnson may be able to do it in 10 motions, 300 pounds 10 times. The other person may be able to do 100 pounds with each motion, but they have to do that 30 times. But the result is the same. If we reduce the work, reduce the resistance, so lower weight, then that weaker structure can create a comparable output. That's what afterload reduction is. So how are we going to determine this? There are tests we do that help us evaluate in pulmonary edema, whether it's cardiac or non-cardiac. And one of the simplest, non-invasive, and relatively inexpensive tests we do is an echocardiogram. An echocardiogram lets us look at the heart and see how the muscle is functioning and if there are structural issues in the heart. That can tell us if that's abnormal, we've got some cardiac issues. If it's normal, if the heart's squeezing normally, looks normal, then we have a non-cardiac cause. And we need to look at other things to try to resolve this process. That also helps us know we've got a good muscle, so we can do other things to address this preload, to try to reduce this preload. We have to evaluate kidneys. The heart may be strong. If the kidneys aren't doing their thing, we may have to consider aggressive diuresis or perhaps even dialysis to take the role and the burden off those kidneys and remove that fluid basically manually. Electrocardiogram is helpful, but it is not completely diagnostic. Electrocardiogram can tell us if there's been a myocardial infarction in the past or some kind of cardiac conduction problem. That can identify that, but it's not conclusive. There may be other tests that have to be done. Now, we've mentioned diuretics. We've mentioned drugs that can improve contractility. The other thing we may need to do is use something like albumin, which can help pull that fluid from the periphery. In this case, think of the alveoli as periphery. We can pull fluid out of the alveoli, out of the feet, out of the hands, into the vascular space, and get it to the kidney so the kidney can remove it. So we may be using one or multiple of these, multiple angles, to help address pulmonary edema. This picture kind of helps you get an idea for a normal process in the evolution of pulmonary edema. I say normal process in the evolution of pulmonary edema, not a normal thing. This is not normal. So for whatever reason, the patient has an increase in sodium consumption. There's an increase in sodium in the patient's bloodstream. And I'm not necessarily talking about hypernatremia, but relative to what the body's experienced. So the body senses an increase in sodium. The hypothalamus will send a signal to increase antidiuretic hormones. In the presence of sodium, the body is going to say, well, we need to balance this sodium, so we need antidiuretic hormone or vasopressin to retain fluid and increase fluid relative to this sodium. This ultimately produces in this population an excess in fluid, which creates a hypotonic state. So they've got more fluid than they need based on this process. With that increased fluid, then they have increased volume and increased preload. The sodium's diluted. So the kidneys then say, well, sodium's diluted, then we need to tighten up and we need to retain some sodium. So the kidneys are going to secrete renin, which is going to tell the liver to release angiotensin 1, which is going to cause the conversion of the lung is then going to convert angiotensin 1 to angiotensin 2. Blood pressure is going to go up. That's an increase in resistance. And with that is going to facilitate sodium retention, in addition to aldosterone concurrently telling the kidneys, the adrenal glands, to conserve sodium. So now we have a tightening up, increased resistance. We have a conservation of sodium. We have an increasing fluid. And then now we have more fluid and more decreased cardiac output, more resistance. So that's going to produce more fluid retention, and more fluid retention back into sodium retention, which also retains water. The stretch receptors get stretched, and we have an increase in atrial natriuretic peptide and B-type natriuretic peptide, which produces vasodilation. So you can see how this is kind of a self-feeding problem. I don't expect you to memorize these steps. I want you to understand the process by which this evolves and how it ends up being a self-feeding process. You should have a firm grasp of the renin, aldosterone, angiotensin pathway because it undergirds this whole thing. So from a nursing standpoint, what are we going to do? Let's suppose so talking about the treatment's been implemented. What's our role in caring for the patient? Well, as treatment evolves, we need to keep putting the stethoscope on the chest. Now, I say here, keep listening. That just refers to being dialed into your patient, not just listening to their lungs, but listening to them. What are they telling you about the way they feel that they're breathing, or the experience they're having in their body. Dial in to their descriptions of what's going on, but also keep using that stethoscope. You've heard me say more than once, an assessment is a 12-hour event, not a 20-minute event. So you're constantly assessing and reassessing. You may use your stethoscope every hour on a particular shift because you have a patient who needs that much auscultation. So that is critical, is that ongoing assessment. How's the edema doing? What does the urine output look like? How much is there? How much is he going to the bathroom? All of those things, that perpetual assessment. And then good communication with the physician. Now, for good physician communication to happen, you've got to know your patients, know your medications, and keep assessing. These things are all integrated because you need to know if your patient has been on diuretics before. Do they have any kidney issues that may impede the capacity for those diuretics to work? You're with this patient for 12 hours. The doctor comes in, writes the prescriptions. So you need to know what those medicines do relative to this whole heart failure or pulmonary edema process. How do the diuretics contribute to function? How do beta blockers contribute to this process? How does digoxin contribute to this process? A good example here is, think about a patient who has a heart rate of 55 and a blood pressure of 100, and they have pulmonary edema. This patient would benefit from digoxin to improve their contractility, diuretics like Lasix to also improve the fluid removal. Now, digoxin is often held for a heart rate less than 60. Lasix can also be held, Lasix and digoxin could be held if a blood pressure is too low. Where this comes together is knowing that Lasix can drop your blood pressure, digoxin can drop heart rate or blood pressure. Knowing your patient tells you that this will tell you, oh, this patient has been on digoxin for 20 years. Their heart rate is 50 at home. So 55 is reasonable for them. This is not going to make them drop their heart rate. Their blood pressure lives around 90 to 100. So a blood pressure of 105, 110 is plenty of blood pressure to give this Lasix, and they need fluid removal. This is an example of where knowing your patient and knowing those medications comes together. So similarly, related to physician communication, this same patient perhaps has a blood pressure that's 90 or 85. You know that Lasix could potentially drop out that blood pressure, and they normally live at 105, 110. So before you give your Lasix, then you need to be in conversation with your physician to say, hey, they sound a little crackly, but the blood pressure is this, and I've got Lasix coming up. And that may result in, well, let's give him or her some albumin 30 minutes before we give the Lasix, which is going to help draw some of the fluid into the vascular space and give some blood pressure room to give that Lasix. So this is what I mean about knowing how your medications come together in this puzzle, again, with the knowledge of your patient. Patient positioning is important, obviously, for optimal oxygenation. These patients are going to prefer to be sitting up, so we want to keep them sitting up. And then when it comes to diet or intake, we want to be thinking about fluid and sodium restriction. So obviously these patients who have pulmonary edema do not need more sodium, and the doctor may impose a fluid restriction. So helping them be compliant with the fluid restriction becomes critical in helping to maintain and manage their pulmonary edema or help improve it. Now, in the next slide, we'll begin discussion of pulmonary embolism. So we'll put the pause button on there, and we'll see you next time.